Another area that's really interesting is the looking at the BCL2 inhibition. So venetoclax, or ABT-199, is the current molecule that's in clinical trials. It's been looked at either alone or in combination with a number of different agents, and does appear to be quite promising. Now, the original venetoclax studies for recurrent CLL, it was so effective, it was actually too effective. They had patients that had tumor lysis, and there were actually a couple of deaths early on from tumor lysis, because it was so effective. So they went back and kind of re-engineered the clinical trials, and is now much safer. It's given at a very small dose to start with and stepped up over time, and has now been found to be much safer. So there's a lot of clinical trials with this because it's probably an enhancement to a lot of the other molecules we just talked about in the B-cell pathway, or potentially anti-CD20 antibodies. And lots of combinations are being looked at for CLL and for other indolent or even aggressive types of lymphomas. So one really rational combination is combining the ABT-199, or venetoclax, with PI3 kinase delta inhibitors. This has been looked at in animal models and found to be very synergistic. And so there are several clinical trials trying to combine these two together that we'll be hearing about over the next couple of years. Next slide. So future directions for these, I think what we're going to be seeing is a lot of combination therapies based upon scientific information, which is always important, but we have to see what happens in the patient, and of course for enhancement and for toxicity purposes. We want to target it probably on specific types of lymphomas that are predicted to have higher response rates, and some of the scientific information I talked about earlier would help us with that. We don't know the sequencing or the combination that's the best. Do you want to do one versus one together, or do you sequence it? Don't know that. We don't know if we should continue with the duration. So right now, for the most part, on these oral agents, PI3 kinase inhibitors or the BTK inhibitors, you continue them sort of until they don't work. We don't really know if we have to do that or not, and those are studies that we have to look at. Next slide. So these are some of the studies we just talked about, the different types of lymphomas and responses, and you can see they're kind of all over the board here, but I think what the important thing is that we need to make sure that we get the patients on the trials to be able to understand this. We can't really look at 3 patients that have been treated and know for sure that this is going to be the right thing for that type of patient. So we need to make sure we have adequate information on large numbers of patients on trials. So kind of what's the future of cancer investigation or cancer care? So I think cancer genomics are something that's very important. So right now on the left, we maybe have one target in a specific type of lymphoma we're looking for, but I think in the future, on the right, we're going to need to know all of the molecular information on the patient's tumor and probably the patient's makeup, their microenvironment, to know what the type of treatments are. So in the future, I think we're going to be identifying these molecular analyses and trying to target probably oral and IV or combinations of therapies for specific patients based upon their molecular analysis of their tumor. Next slide. So these are some benchmarking of genomic analyses for different types of lymphomas. You can see on this slide. And looking at the potential different abnormalities, either mutations or modifications. The P53 is the one that's the most common in different types of lymphomas, but you can see there are a number of different ones that potentially we can target. So I think that genomic alterations are going to be something we're going to really need to know about in the future for individual patients. Next slide. So this is just kind of a conceptual idea of how to use that information. So let's say we take a patient with lymphoma, we do molecular analysis on their lymphoma, and then we subset them into the different types of lymphoma that they might have, and the different types of trials that would be appropriate, or different types of treatments that would be appropriate for that patient based upon that information of what kind of mutation they have or what their specific analysis is. And in that way, we can try to make sure the patient's getting therapy that has a much higher rate of being able to improve their outcome, and hopefully decreasing healthcare costs overall, because we're targeting just therapies on patients that have a much higher chance to respond to them. So, kind of the future of lymphoma and CLL research, I think, is genomic molecularly directed therapy. This is not really something that's ready for prime time. This is obviously all still in clinical trials and analysis. Biomarkers driven for clinical trial, I didn't talk much about that, but that's also another area of investigation. Probably more use of the pathway associated agents, either alone or in combination, and perhaps less cytotoxic chemotherapy. And I think combination probably in the future, that's directed combinations is going to be the way that we're going to see that. Next slide. So I want to talk about just a couple other programs that are sort of related to that ASCO is doing. CancerLink is a program that's just kind of becoming online this year. And CancerLink is a big data program from ASCO, a crowdsourcing, if you will, program, where it's called the Rapid Learning System. So information is going to be taken from electronic medical records directly into a large database that will allow sort of crowdsourcing of information, looking at patients' demographics, molecular analysis, types of diseases. This is for all diseases, not just for one disease. And transform and aggregate the data. The data is going to have a couple of different ways to be used locally for quality assurance for that individual location, and then also crowdsourcing together to look at a way to do scientific investigation without true clinical trials. So we can look at the types of cancers, the types of treatments, the types of molecular analysis if it's available, and try to put that information together on thousands of patients. So this has been worked on actually for a number of different years with ASCO, and they're working with a company called SAP, which has a technology to be able to aggregate this data and to kind of do the analysis instantaneously, which is a really interesting technology. So they're going to have a number of different centers. There's I'm going to show you in a minute a pilot of about 15 centers that's going to be ongoing this year, 2015. And eventually they hope to get thousands of centers that work with them on that. A couple of different databases. One database is available to the local institution or the physicians at that local institution to be able to do quality assurance. So it's going to basically take over COPI, which is the quality program for ASCO. And so for that local institution, they'll be able to use this for their COPI. And then they aggregate all the data together from all the different institutions, that's de-identified data, no patient information, to be able to do these large-scale research studies on. And so we're really excited about this. That's going to be available in 2015. Next slide. So these are the centers that are going to be participating in the kind of pilot project for CancerLink. That one up there in Omaha is us. I decided that if I'm going to be the president, we have to participate in this and make sure they have primary information on how this works. And then various different centers, about 350 physicians, and the records of about 500,000 patients are going to be aggregated in 2015 for the initial pilot. So additional functionality eventually through the system will be trying to access clinical trial eligibility, creating longitudinal treatment plans for the patient, and trying to make sure that the summary documents are available, risk stratification. The other area that we're really interested in looking at is the potential for accessing outcomes on patients post-marketing, so kind of like phase 4 studies, except you don't really have to do the study. And also trying to potentially look at patients that are treated in off-label indications and what their outcomes are, and that's really hard to get that information currently. Produce products and reports, again, on de-identified data. The other study I want to talk to you about is the NCI MATCH study, and this is a couple of different studies trying to look at, can we take newer medications, trying to do what I talked about earlier, molecular analysis, and direct the patient towards whatever type of treatment seems appropriate based upon their molecular analysis of their tumor. Next slide. So this is just going to be open over the next month, I understand. And it's going to require samples to be sent to the NCI, and they're solid tumors or lymphomas that are eligible for this. And these are patients that have failed standard therapy. So they have a genetic analysis done on their tumor and look to see if there's an actionable mutation on the tumor. If there is, and there is a agent that's available in the study for that, then the patient would be referred onto the study to receive that medication. So as I said, patients with multiple solid tumors and lymphomas who have progressed on at least one standard of care therapy are eligible for this. They have to have a new biopsy for this to be able to undergo that, and kind of typical analysis for patients that are on studies. Next slide. These are the actionable mutations that we know about as of today, and of course that's changing daily, and then percentage. So there's a lot of ones that have very small percentages that are potentially actionable with the agents that we have. And this study doesn't have all of these in the study, but hopefully over time what will happen is as drugs are tested and either are successful or not, then they will drop out and new drugs will be added. Next slide. I think this is one where you have to build it also. So this is kind of the workflow. The tissue is obtained, and the 11 to 14-day turnaround time is what they quoted. They're doing genetic analysis on the ion torrent machine and trying to look at the selectability of the different agents based upon this. Next slide. I think you can go to the next one. So these are the sub-protocols that are going to be available at least at first. As far as the different agents that are going to be looked at, you can see that the agents there and the target. So these, for the most part, are they're either available agents or some of them are investigational, but they're being looked at in this case for different diseases where they're not currently FDA approved. And these are the actionable mutations that are in the percentage that are present. The other one I want to talk about is a new study that's going to be through ASCO. This is ASCO's first clinical trial. It's called the TAPER study. And this is being led by Rich Schultz, who's the CMO from ASCO. So